Thank you all for joining us today. I'm glad everyone could join us in person for our Pharmacy Discipline Group Session 10, the Inside Scoop, Acute Care and Highly Effective Modulator Therapy Era. I am Kelsey O'Keefe, a certified pharmacy technician in the Cystic Fibrosis Ambulatory Care Clinic at SSM Health Cardinal Glennon Children's Hospital in St. Louis, Missouri. My co-chair today is Dr. Bradley McCrory, who is a clinical pharmacist at Cincinnati Children's Hospital Medical Center. Today we're going to have Dr. Jennifer Ott, who goes by JC from Montana, talk about newer antimicrobials. Then we're going to have Dr. Bradley McCrory from Ohio talk about non-tuberculous Mycobacterium treatment, followed by Dr. Catherine Hobart from Arizona, talk about allergic bronchopulmonary Aspergillosis. Then finally, we'll have Daniel Killian from Utah discuss transitioning phases of care within a pharmacy technician role. In this session, we are going to focus on 3 objectives. One of our objectives is to describe the use and dosing of newer antimicrobials in the treatment of pulmonary exacerbations in patients with CF. Secondly, describe the use of medications to treat allergic bronchopulmonary, Aspergillus, and non-tuberculous Mycobacterium with concomitant use of highly effective modulator therapy. Lastly, describe the role of a pharmacy technician in continuity of medication regimens for patients with CF that are transitioning phases of care within a CF center. We are hoping to spark some good discussions today. We encourage you to be involved by submitting your questions throughout each of the presentations. We will take about 5 to 10 minutes at the end of each presentation to have the speaker answer any questions you may have. So to submit your questions, just open your app on your phone and locate session DG10 Farm. Then click the Q&A button located at the bottom navigation bar of the session detail page. Okay, so I would like to introduce our first speaker today, Dr. Jennifer J.C. Ott, who is the clinical pharmacy specialist of infectious diseases at Billings Clinic in Billings, Montana. Part of her role for 8 years is advising on antimicrobial agents for both the pediatric and adult centers. So I am going to turn it over to Dr. Ott, who will be going over newer antimicrobials.
Set my timer so I don't talk too long. I love nerding out over antibiotics. Making it talk back to me.
It's a little hot today.
It is a hot mic today, you were right. All right. Is it the mouse button?
You have to advance one slide on the laptop and then the mouse, and then
Perfect.
that clicker will work.
Perfect. I have nothing to disclose. So I wanted to touch base about a couple of newer antimicrobials today. So really going to start out with sulfidiprol. How many of you use this drug? There's a few. Imipenem, rilabactam, ceftaz, AV, a little bit on Toltezo. There's a couple new things potentially coming out. And then talk a little bit about ibrexafungerp and then mirovaber. And there's so many more things I'd love to talk about. We just don't have time. So kind of focus on things that we tend to be seeing a little bit more in practice. So sulfidiprol is kind of this fun antibiotic. It's got this side chain from ceftaz. It's got this side chain from cefepime. It has this catechol moiety, which actually is really, well, it's kind of nerdy, but it's kind of fun. So they call it the Trojan horse because it comes in and it binds the iron, and iron has an active transport system that comes into the periplasmic space. So it kind of sneaks in with the iron, which is really cool, very different than what we see with our other antibiotics where they just kind of have to diffuse across the membrane. And then once it gets into the periplasmic space, dissociates and acts just kind of like a cephalospore and binds to penicillin binding proteins. It's a little bit different of a mechanism, which does allow for a little bit different activity than what we see with some of our other agents. So this one's, if you don't like extended infusion, I apologize. You're probably not going to like my talk today because most of these are all extended infusion antibiotics, and I apologize, but I don't have a great option. for most of these are time dependent. This one's 2 grams Q8 over 3 hours. Renal dosing is required. The safety data so far looks actually pretty good. There was some initial concern, right? If it binds iron, are we going to see some issues with iron homeostasis and anemia? That has not been seen in randomized trials. That being said, it's not super widely used yet, so there may be other potentials coming out. And I'm more so curious for those of you that are using Cifridercol, are you guys testing in your lab? Lots of blank stares. Yeah, so this one's kind of a challenge as far as testing goes. It requires broth. So broth microdilutions are gold standard, if you will, which is also a pain in the neck to do. It's very time and labor intensive. And so when we do broth microdilution, there's kind of this tail that comes, but you also have to have iron depleted media. So that's a little bit harder to get. There is new disc testing that's available. I did put a picture of kind of the paper that was published. There are some nuances. It's a little bit more difficult to read when you start having these colonies kind of pop up in the middle. Clearly, I'm a micro nerd. And so there are some testing issues that we do have with this drug. I know we can't get this drug at our center for testing capabilities in our lab. I'm also kind of a rural center. Our micro lab's fairly small. So bigger centers, academic medical centers, is where you'll start to see testing for this drug. It tends to be a send out, so it's not a super quick return. But it's cool because it covers very broad spectrum, carbapenem-resistant Enterobacterales, difficult to treat Pseudomonas, even some carbapenem-resistant Acinetobacter, and some steno. So there's this is a table of a compilation of Pseudomonas isolates. Most of this data actually is published in 2020. Ironically, from 2020 on, there's really not a whole lot of antibiotic stuff that's published. Everything kind of went towards down the COVID train. So I highlighted the red for the Cifridercol. Cifridercol breakpoint, we're looking for less than or equal to 1 for Pseudomonas. And so at all Pseudomonas isolates, the MIC 90, so 90% of the isolates had an MIC of 0.5 or less, so it's pretty good. And then they looked at meropenem-resistant isolates, MIC 90 is 1. When you looked at ceftazidime AB Bactam-resistant isolates, the MIC was 1 to 2, so we're getting a little bit higher, but still within that appropriate realm. And then when we looked at ceftolozane tazobactam, which is the 4th line down, our MIC 90 is still 1 to 2, so we're still looking pretty good for Cifridercol, at least in vitro data. And this was kind of cool. When they look at steno, the MICs are pretty low. We have the North American isolates and the European isolates, and our MIC 90 in the US at this time was 0.5. So this is before widespread use of Cifridercol, so things can change, right? We get new toys out and then we break them fairly quickly. So that's a definite possibility of things that could come. But the other thing that's cool is there's some Burkholderia in vitro data. So keep your eye on that space. We'll definitely expect to potentially see more coming as more of this gets used. They had some initial trial data looking at UTIs, looked pretty good, pneumonia looked pretty good. And then they had this really cool study where they looked at carbapenem-resistant gram-negative infections, took all comers, Cifridercol versus BAT, which was kind of a fun word to use, best available therapy, which is what we really want it for, right? Those resistant organisms, we want to stop using drugs like colistin. It had really great clinical microbiologic outcomes, but then you looked at the mortality rate, and it was higher with Cifridercol. You're like, ooh. So everyone was like super excited, and then when this was published, you're like, so maybe it's like not the wonder drug. So there's potential definitely for this drug. There are some caveats. There's a lot of arguments in the ID world about why this number is higher and what we expect to see going forward. So it's just something to keep in the back of your mind. There's a little bit of CF data that's published. So those of you that are using Cifridercol in your center, you should write up some case reports and case series. Mostly seems to be with resistant Achromobacter. This kind of seems to be the ugly bug that pops its head up. The dosing in the pediatric case study was 60 milligram per kilo Q8. There was really no PK/PD analysis. And then there's some older patients. And then there was a nice case series looking at Achromobacter, looking at 12 courses in 8 patients. They had pretty good clinical response. 11 out of 12 patients had clinical response. So definitely need some further studies, but really excited about this drug in this space. And as I'll tell you today, each of these drugs, there's like kind of these clinicaltrials.gov, more things seem to be coming out, so we're very excited about this. They're looking at adult CF patients with Cifridercol. This will be kind of cool, looking at the 3-hour infusion. There's some debate with Cifridercol. If you have really high creatinine clearance, there might need to be more frequent dosing, so Q6, which 2 grams Q6 over 3 hours. Gives me a little bit more anxiety. We struggle right now, we're nursing shortages, how to get these things. And then it's also not conducive to sending somebody home in that setting. So that's estimated to be completed next summer. So what to do with this drug in the meantime? This is kind of my personal opinion. It's very broad spectrum, looks great in vitro. It is difficult as far as the testing is concerned. Great for difficult to treat Pseudomonas when our other beta-lactams, either we can't get them because all good things start with this drug was on shortage. And then there's other bugs that we're starting to see in CF, those multi-drug resistant Achromobacter type situations. This drug might have some utility in those places. Imipenem relebactam, how many of you are using this drug? So like maybe 2 people. Awesome. So we talked a lot about this drug because Septolizane tazobactam went on shortage. And then I really started to look at the Pseudomonas data, and it actually looks pretty decent. So imipenem, cilistatin, relebactam. Most people are familiar with imipenem, cilistatin. Relebactam is a new beta-lactamase inhibitor. It's kind of fun. We have all these new beta-lactamase inhibitors, except they're all in combination with something very specific. So in my world, we're like, well, I'd like to use, this beta-lactam with this beta-lactamase inhibitor, but I can't quite do that without combining really expensive drugs. This one was looked at for UTIs, intra-abdominal infections, and pneumonia, which is pretty standard. You'll see for almost all these agents, that tends to be the indications. And here's where we get into fun in the pharmacy world. They take all this stuff and combine it. So it's listed as 1.25 grams every 6 hours. Now, depending on how many of you work with peds? So lots of you. Okay, so we have adults and peds at our center, and we have Cerner, and I hate it because sometimes it adds the whole drug into one, and then other times it's separated. So like amoxiclav, it's amoxicillin dosing in the computer, but like pip-tazo, it's all added together. And so it's high propensity for dosing error, so just something to be aware of. Most of these are dosed in the adult world, everything's added together, and then when we get into pediatric world, it becomes more complex, especially depending on how you have your EHR built. So for all intents and purposes, it's 500 milligrams of imipenem, cilistatin, and then 250 of relebactam. Pretty well tolerated, fairly similar to imipenem, cilistatin. We do concern about seizures, especially those are the patients, especially if you don't renally adjust, and then potentially with ganciclovir. Also, carbapenem's lower valproic acid levels, something just to be aware of. Otherwise, it looks pretty similar to what we see with regular imipenem. Couple studies, intra-abdominal UTIs, and then the Restore-IMI studies are kind of fun. The Restore-IMI 1 was looking at imipenem non-susceptible isolates, so it's the third one down there in the white. And then we had, so imipenem relebactam versus imipenem plus colistin. And so colistin's really fallen out of favor in the ID world. There's been some really nice publications suggesting why we shouldn't use it now that we have these new drugs. And it imipenem relebactam looked really good in this study, and the Restore-IMI 2 study was a non-inferiority against pip-tazo for pneumonia, looked pretty good. Of course, none of that is cystic fibrosis. So what do we do with our CF patients? So we go back and we look at, okay, so what does relebactam add to imipenem? What am I gonna gain in this space? And this is a little different than when we had meropenem Vapor come out. Vapor didn't really add anything for Pseudomonas. But in this setting with imipenem, relebactam gave us some additional Pseudomonas coverage, which I think is why we're seeing a little bit more data come out about what we're gonna do with CF patients. So the underlined red line is imipenem relebactam, and really looking at the third number column to the side, 97% susceptible in this Pseudomonas isolates. And the line above it is the imipenem, so it went from 78% susceptible to 97% susceptible by adding relebactam, so gained quite a few isolate susceptibility in this study. And then we kind of get to nerd out. This was published in 2020, and there seemed to be a lot of excitement, and then COVID happened, which kind of killed everything. But they looked at this in vitro data with Mycobacterium abscessus. And so the top graph has, it's a zone of inhibition, so we're looking at Kirby-Bauer testing, and it has amoxicillin in the dark boxes, which if your zone's really small, it's resistant. And then you add the relebactam to the amoxicillin, and then you gain susceptibility, so that's the gray bars. In most isolates, it seemed to do pretty well. And then they looked at, well, what if we add a carbapenem to that? Because, like, for example, we know imipenem has baseline activity. So if we're inhibiting the beta-lactamase of abscessus, so the best was actually seen with imipenem, amoxicillin, and relebactam. And granted, this is all in vitros, but it's kind of encouraging, kind of exciting things that are potentially coming out. They also looked at Avibactam, which also did inhibit the beta-lactamase. But Avibactam comes with ceftazidime, which is just kind of a crummy drug in and of itself. It doesn't have great activity against sepsis. So your option, if you're going to use Avibactam, is now I've got to combine ceftazidime, Avibactam with something else, which just seems logistically kind of a nightmare for patients. You're talking about multiple infusions. Generally have to get a double lumen PICC line because we don't have like capability to do testing or compatibility data. So it just turns into a nightmare. So really these graphs are showing that when you have ceftazidime, Avibactam, you don't really see any change in the MICs, but when you start adding the carbapenem to the Avibactam, we see good activity. Someday if they come out separate, it might be something worth looking at, but all this data kind of stopped when COVID came out. So this is something to keep your eye on in future spaces. And my last point with imipenem, looking at multi-drug resistant Burkholderia. So this was kind of a really cool study that came out looking at our susceptibilities. So ceftaz-AV on the right or the left-hand chart, ceftaz-AV has MIC 50 and 90s of 4 and 8, so pretty decent, considered susceptible. But when you look at Burkholderia that is ceftaz-AV resistant, which is the table on the right-hand side of the screen, imipenem relebactam still retained activity 70% of the time. So when we start to see these more resistant organisms show up, just depending on susceptibility. That being said, as much as I like imipenem relebactam, testing is also a nightmare with this drug. Do any of you have testing of this drug in your lab? So very few. I saw one hand go up. So that's potentially problematic if you can't test the organism. So I know in our lab it's a send out. Sorry, I'm just handing you all my papers. I'm like old and can't read on the screen, so I had to print them out. I apologize. So imipenem relebactam, there's a couple of clinical trials that are potentially coming out. This one is sponsored by Merck, looking to be out in February of 2024. So not super soon. So there'll be some new data coming out. This is really looking at our pediatric patients trying to get appropriate dosing. There was initial phase 1 study looking at 15 milligrams per kilo of the imipenem, 7.5 milligram per kilo relebactam every 6 hours. And so I'm really excited to get the PK data. There's a CF study. Let's see. There we go. There's a CF study expected out in December 2023 looking at adults and adolescents. This is from Dr. Cuddy's lab, so I'm really excited to get some CF data. Again, they're looking at that same pediatric dose that the PED study is looking at, which this will come out first, or the 1.25 grams every 6 hours. So more things coming. And then ceftaz-AV. Who uses this one? Quite a few more, yeah. So this one's a little bit newer. Most people are probably a little bit more familiar with this. Same indications as our other drugs, intra-abdominal UTI, and then pneumonia, which mostly we care about pneumonia for the most part. So looking at adult dosing, it's 2.5 grams, so 2 grams of ceftazidime, 0.5 grams of Avibactam. The package insert tells you to infuse it over 2 hours. In the MDRO guidelines from the Infectious Disease Society of America, these are all infused over 3 hours. So that's always a fun debate, which infusion rate do we pick? Just for example, at our institution, we do 3 hours just to standardize everything because we run our others over 3 hours. And nurses get confused, this one's 2 hours, this one's 3, and then this one's 4, and it just caused a lot of confusion, so we just standardized ours to 3. There is pediatric dosing of this. Technically, it's not approved for pneumonia. On the flip side, we don't, at least in my world, we never use anything on label, so that part really doesn't bother me. This one's kind of cool, has some carbapenem-resistant Enterobacterialis data, some difficult-to-treat Pseudomonas data, and then we looked at there's a CFPK study looking at the dosing. This one's a little bit older, which is probably most people are familiar with it. Looking at 12 CF patients, 2.5 grams of ceftaz-AV over 2 hours, had a really high probability of target attainment. So looks relatively similar in CF compared to non-cystic fibrosis. And then looking at all the fun graphs of our MICs. So looking at, this is a table, this one's kind of an ugly table. Looking at our Pseudomonas isolates, these are multi-drug resistant Pseudomonas isolates. So by definition to be in this study, they looked at CF patients who had ceftaz or cefpime resistant isolates. So the fourth column over is your percent susceptible, which is why cefpime and ceftaz are at 0. And then ceftaz-AV retained activity in quite a few patients, so 71.9%. Okay, it's a small study, it's 32 isolates from 28 patients, but it does give us the capability to have these still. I was kind of bummed that they didn't test other medications in here. So then looking to see what else we have, what other data we have. This is a more broad picture of Pseudomonas isolates. So we have ceftaz, AV, CLSI is essentially what sets the US breakpoints, UCAST is the European breakpoints. And the top lines, we have ceftaz, AV about 96% susceptible, Toltezo at 91. So these still retain pretty good activity. And then we're starting to see some case reports and case series pop up with Burkholderia. And that's kind of the fascinating space. Granted, these are all pre-COVID, so if you're using this during COVID for these, please publish it. Give us some better data. The last one on the bottom right is a case series of 15 courses and 8 patients. And there were 4 Burkholderia patients. Everybody had Pseudomonas in addition, and they had an 86% response rate, so it's pretty high. So keep your eye on that space. And then Toltezo, which is ceftolozane tazobactam. This one I feel like, I don't know, anecdotally, a lot of us are more comfortable with. This came out and was going to be this really good Pseudomonas drug, and then it went on shortage for a really long time. It came back at Christmas last year, so we always joked around this was our Christmas present from the drug company for a really ridiculous price tag. But this one was kind of our clutch drug when we had resistant Pseudomonas. It's easier to test. It's on a lot of commercial laboratory testing panels. It's 3 grams Q8. You can debate the infusion time. IDSA guidelines recommend 3 hours. Package insert is not quite 3 hours. So depending on how you set things at your center, there's not a lot of data debating 1 hour versus 3 hours. And so there was a CF study looking at 3 grams Q8 had really high probability of target attainment, so fairly similar PK as seen in non-CF. And it was just really a less volume in the central compartment was really the difference. Also requires renal adjustment. And then pediatric data, we're kind of getting a little bit more pediatric data. This was a case series looking at Toltezo, and that middle line has lots of different treatment options. So they had 50 milligrams per kilo over 3 hours, Q8, 40. The next one used 44, then the next one used 31. So there's a lot of different doses that we're kind of seeing initially. So there's 2 PK studies looking at CF patients. So the first one looked at, well, if we do 20 milligram per kilo of ceftolozane, 10 milligram per kilo of Tazo, so 30 total, is very similar in the adult world to the 1.5 grams, which for Toltezo, for 1.5 grams, we use that for UTIs, intra-abdominal infections. So it's kind of like half the dose. So then the second group went back and also published in the same year, and they were like, well, so the pneumonia dose for peds is double that of what we see for intra-abdominal. So it's actually the pediatric data is following the adult data here, which is it's a really good thing, I think. So that's how they came up with the doses that they're using in these studies. They're looking at a pneumonia study, looking at 40 milligrams per kilo of ceftolozane, 20 milligram per kilo of tazobactam infused over 1 hour in this study. This is a Merck study expected out in 2025, but the 60 milligram per kilo total product seems to be maybe what we're using. All right, a couple of miscellaneous ones. Has anyone used ibrexafungerp? So I just put it on here mostly because, so it's a new one that came out last summer. I don't know about your experience. We do have a lot of patients who, we give them these super broad spectrum antibiotics, and then they wind up with vulvovaginal candidiasis. And historically, we've used fluconazole. Sometimes we reach a point with fluke where it just doesn't work. And so that's actually where this drug comes into play. It's kind of our first new triterpenoid antifungal antibiotic. It's a brand new class. It's a short course for vulvovaginal candidiasis. They had a 71% response rate in clinical trials for patients who didn't respond to fluke. So it's pretty high. And then the fun part, because most of our patients are on modulators, it is a 3A4 PGP OATP 1B3 inhibitor. The package insert's like, it's a short course, like don't worry about it, but just keep it on your radar because they are looking at higher doses for more serious fungal infections, which will be problematic potentially in our patient population. And then Mirapen and Vaborbactam, and I didn't really spend a lot of time on this one because Vaborbactam doesn't really gain us extra Pseudomonas coverage or Acinetobacter or Steno. It is really good for those, what we call CREs, carbapenem-resistant Enterobacterales, so our KPCs, Ambrocas A and C. It's a beta-lactamase inhibitor. It's really cool from the ID perspective, patients that were dying before we can now treat. At our center, we don't have a lot of those isolates in our CF patients outside of a few Achromobacters, so that may become its niche in CF. It was kind of fun because they only studied it as an extended infusion, so it's 4 grams over 3 hours every 8. So maxing out your meropenem dose. There is a case report in a cystic fibrosis patient, 10-year-old, with a Chromobacter. In all fairness, so this patient had sofriticol, Mirovaber, and phage therapy, had a really decent outcome. There is a Tango Kids, there's a pediatric study going on right now looking at the 40 milligram per kilo meropenem, 40 milligram per kilo Vaber-Bactam every 8 hours. And then the first 2 cohorts looking at that, the Data Safety Monitoring Board came back and they're like, we're gonna look at 60 milligrams per kilo. And you're like, that's really high meropenem dose, that's impressive, in ages 2 to 6. And so that's actually expected to come out next year. So hopefully we'll have some better pediatric Mirovaber PK data to drive our appropriate dosing. So to summarize, we have all these kind of new antibiotics. New antibiotics are never cheap. So they cost about $800 to $1,100 a day. I listed the dosing here, and I kind of put a few more things in the next slide. So try to put this in a table of like how this is how I envision these. You know, we're reminding me that I need renal adjustment. All these are 6 to 8 hours. So it's not super conducive to going home. Hopefully we'll get some better, maybe continuous infusion data, which may be able to, for stability for things like Toltezo, those kind of things, we could potentially send those patients home on continuous infusion. PEDS data is not super strong yet, and we're still working on some CF data for some of these drugs. So those of you that are using it in CF at all, please, by all means, get your data out there. That would be super helpful for those of us that don't use it very often. Also, we have difficult to treat Pseudomonas. We have some new agents, which is really exciting for some of those more resistant, ugly isolates. And then we've got some in vitro data for Burkholderia and Steno, like with Sofriticol and with Cas-AV. So some nice things in the pipeline to consider and think about. So I'm very excited about that. Are we doing questions?
Yeah,
Sorry.
we'll do questions real quick. So we have about 5 minutes for questions, and you guys are all rock stars. You submitted a lot of questions through the app, so please feel free to do that. Just another thing is that on the iPad up here, I get points if people like other people's questions. So we'll kind of, in this limited question time after each presentation, if you like someone else's question, give it points, and we'll go to the highest point questions on that. So one of the first ones that came through is, are most of these drugs restricted from a stewardship standpoint, and or does CF just get a pass every time you guys hear the word CF?
So it's been fascinating to talk to some of you that do like only CF or only ID, and I do both. So when I have my stewardship hat on, like, yeah, I don't want to use it in every patient, but when I have somebody that's not doing well or historically hasn't responded, it's better to have them have an appropriate outcome. So you're right, it is absolutely a fine line to walk over, like, I have this expensive drug, but it works, or if I'm going to use something my patient hasn't responded, it is a fine line to walk, absolutely. At our organization, they are restricted, but it's cheating because I'm also the stewardship pharmacist, so I may have a little more leeway there. But we have those conversations, and my pulmonary providers are very well aware, like, the more we use these, the more we lose them. And so they do understand that if we give these to everybody, we do potentially promote resistance. So it is absolutely a fine line to walk. Most organizations probably do have it restricted based on cost.
Awesome. Another question that came through is, could you just briefly discuss for everybody in the room, because you mentioned that there's some newer information that colistin may not be a good option. Could you just kind of summarize in a couple of sentences to why it's kind of falling out of favor? Because I think there's a lot of us in this room that still use colistin.
So most of it's talking about IV colistin, not the inhaled stuff that we sometimes do. So there's a really nice paper. Jason Pogue is one of the authors of it, really talking about, we call it the death to colistin paper. That's not actually the title. But there's an actual statement published in SIDP, kind of owned it, Society of Infectious Disease Pharmacists, talking about colistin. And there's a lot of debate about in vitro data, and actually CLSI essentially took away the ability for us to call colistin susceptible in vitro because it's such a terrible drug, and with the side effects associated with it, and the dosing is so debatable, I guess is maybe the right word, for efficacy. So really when that paper, that policy statement came out, it was really don't use it in the majority of scenarios. But now we have these new medications that really look better. When you looked at imipenem relebactam versus imipenem plus colistin, and the colistin arm did terrible. And then there's another study done with meropenem, and they added colistin to meropenem-resistant isolates, and colistin didn't even change the outcome. So then we're like, why are we adding toxicity in those settings? Okay. Does that make sense?
Yeah. Awesome. And then one last question that's kind of relevant to this session is, did any of these studies that you talked about today that had patients in them with CF, were any of them on Modulator at the same time, or did the studies talk about Modulator use?
Most of the studies were published either 2020 or pre-2020. So I would say not so many. But it's also cheating because Jeff's sitting over there and Jeff publishes most of the data. So, but I don't think many of them were, because everything's early, everything's pre-COVID. And so most of you wrote the papers. Feel free to speak up, I'm just here.
All right, thank you very much.
All right, thank you, JC, wonderful job. Moving right along. Okay, I would like to introduce our next speaker, who just happens to be right next to me, Dr. Bradley McCroy, who is a clinical pharmacist at Cincinnati Children's Hospital Medical Center, working with patients with cystic fibrosis, among other pulmonary disease states. Bradley splits his time between the inpatient pulmonary medicine team and the CF clinic at Cincinnati Children's. I will now turn it over to Dr. McCroy, who will be discussing non-tuberculous Mycobacterium treatment.
All righty, thank you very much. So, yeah, we're going to talk about non-tuberculous Mycobacterium treatment, and sorry. There we go. So the disclosures I have today is that I have no relationships to disclose with regards to the topic of this presentation, but one other disclaimer I will have is that all the medications I talk about today are going to be off-label. So our presentation outline for today is we're going to look at NTM treatment guidelines that are currently out there for persons with CF, and then we'll talk a little bit about NTM treatment guideline issues in the area of highly effective modulator therapy. And we'll kind of close out with some newer medications that are being used for the treatment of non-tuberculous Mycobacterium in patients with CF. So just a little bit of background if people are kind of newer to this topic. Common non-tuberculous Mycobacterium isolates that have been identified in persons with CF in North America and Europe are Mycobacterium avium complex and Mycobacterium abscessus complex. And what's interesting is I actually don't see this at my center, but 72% of positive cultures have actually been for Mycobacterium avium complex in these regions. And then the rest have been kind of this Mycobacterium abscessus complex. So within the avium complex, there's Mycobacterium avium, there's intracellular, and chimera. And then within Mycobacterium abscessus, they're starting to do this fancy thing where now we have 3 names going with bacteria, where we have subspecies abscessus, we have subspecies Bolletii, and subspecies Mycelians. And then other isolates that they have found over time is Mycobacterium simiae, Mycobacterium canaceae, and Mycobacterium fortuitum. So the guidelines, I kind of call them the oldie but goodie. They were published in 2016. This is kind of still the current CF specific guideline from the CF Foundation. For Mycobacterium avium complex, the graphic is up here, and I really love showing this graphic when I have students and residents with me because it kind of is quick to kind of take a look at everything. But typically there is a 3-drug regimen that is recommended for most patients, and that is azithromycin, rifampin, and ethambutol. The duration of treatment is 12 months beyond culture conversion, and culture conversion is defined as 3 negative cultures consecutively, and then the time of conversion starts going back to the first negative culture. And then the guideline also states that patients failing to culture convert may need long-term suppression therapy for their NTM disease. But the issue with this 3-drug regimen in the era of highly effective modulator therapy is, what do we do with rifampin? So just to kind of talk about rifampin's issue real quickly, rifampin has historically been part of a 3-drug regimen for the treatment of Mycobacterium avium complex. However, as everybody in this room is well aware, rifampin is contraindicated in patients receiving CFTR modulators. And this is because ivacaftor, tezacaftor, and alexacaftor are substrates for the CYP3A4 isoenzyme. And rifampin is a known strong inducer of this isoenzyme. And looking at it a little bit more in depth, why is it contraindicated? It's because ivacaftor exposure measured by AUC has actually been shown to decrease by 9-fold when given concomitantly with rifampin. And tezacaftor and alexacaftor, I haven't really been able to find that information, but exposures are also likely to decrease significantly when co-administered. I heard through the grapevine that there is currently a study ongoing at one of our centers, maybe out west, where they are looking at rifabutin in combination with CFTR modulator therapy. If you guys remember, rifabutin kind of has less effect on CYP3A4. And so hopefully that information will give us a little bit more ability to use rifamycins again for treatment of MAC disease. So switching gears a little bit, looking at Mycobacterium abscessus complex, here is the treatment graphic. It is a little bit more extensive than the MAC one. It usually starts out with an initiation phase, which is usually 2 to 3 IV antibiotics coupled with PO azithromycin if your isolate is susceptible to clarithromycin. If the patient culture converts, they go on to a continuation phase, which again lasts for 12 months beyond culture conversion. Again, 3 negative cultures consecutively, and the time starts from the first negative culture. And again, failing to culture convert may mean long-term suppression therapy. But in the continuation phase, it's typically 3 to 4 oral antibiotics coupled with nebulized amikacin, which now we have the liposomal form of amikacin, which makes it a lot easier for patients to do at home. But the problem is on this list, clofazimine is listed, and clofazimine is starting to get a lot of use at US centers for treatment of non-tuberculous mycobacterium. So let's open Pandora's box about clofazimine. Clofazimine is an antimycobacterial approved for the treatment of leprosy in Europe and stuff, and it's used off-label as part of a multi-drug regimen for the treatment of multi-drug-resistant tuberculosis and also non-tuberculous mycobacterial infections. Okay, everybody in this room has had conversations about what are the drug interactions with clofazimine and do we need to be worried about it? So I tried to dig a little bit into this. So there was a study in 2018 that looked at AUC ratio or static models and physiologically based pharmacokinetic or dynamic models that predicted clofazimine to be a moderate to strong CYP3A4/5 inhibitor, which really set off a lot of alarms in a lot of CF centers. And what do we do with this in the era of highly effective modulators? I'm going to get to that in a minute, okay? But I also want to talk about availability of clofazimine that makes it really hard to get. It's limited access in the United States, and for a lot of pediatric centers, we actually have to do a local IRB to our research IRBs and then do a patient-specific IND to the FDA in order to obtain clofazimine. If your patient is over the age of 18, it may be a little bit easier to access it through the clofazimine expanded access program. So those are kind of the two things that we have for accessing clofazimine. So let's look at the drug interactions a little bit more, and do we actually need to be worried about these? So in this study in 2018, looking at clofazimine's effect on bedaquiline and its metabolite M2 metabolism, they found that clofazimine showed a slight increase in clearance of bedaquiline and M2, but it was found to not be significantly statistically significant. And I have the information here for you guys. Earlier this year, I was really excited to find this article. Earlier this year, there was an article published about the use of clofazimine concomitantly with CFTR modulator, tezacaftor, ivacaftor, and its metabolites. For ivacaftor, the AUC actually increased about 1 to 1.5 over 115 days of therapy. And then its active metabolite, hydroxymethyl ivacaftor, the AUC increased about 1.5 to 1.7 over the course of the treatment. There's an asterisk next to ivacaftor carboxylate because that is actually an inactive metabolite of ivacaftor, but they did show that it increased at a ratio of about 1.7 to 2.6. But again, that really doesn't play into a lot of what we're concerned about because it's an inactive metabolite. And then tezacaftor did something that I'm still perplexed about looking at the data. It actually had a ratio change of a 0.75 to 1. And one thing I learned when putting this presentation together is that the FDA actually has a guidance document for industry on how to classify inhibitors and inducers of isoenzymes. And so if you actually look at the FDA guidance document to the industry, weak inhibitors increase the AUC of sensitive substrates 1.25 to less than 2-fold. Moderate inhibitors increase the AUC of sensitive substrates greater than 2 to less than 5-fold, and strong inhibitors are greater than 5-fold. So if you look at this data that we talked about with bedaquiline and then with the CFTR modulators, this would actually put clofazimine in the weak inhibitor of CYP3A4 classification. So hopefully that clears up some of the discussion in the room. But still, clofazimine and rifampin, it's not the greatest options. And we are actually starting to see increased use of other antimicrobials that I wanted to talk about for the rest of this time. So let's talk about bedaquiline. Bedaquiline is a diarylquinolone antibiotic approved for the treatment of multi-drug resistant tuberculosis, and it is actually approved for patients greater than 5 years of age and weighing greater than or equal to 15 kilos. Its mechanism of action is that it inhibits the proton pump of Mycobacterium ATP synthase, decreasing ATP production. Its dosage forms that are on the market are 20 milligram tablets and 100 milligram tablets. And for patients who cannot swallow solid dosage forms, it's actually recommended to use the 20 milligram tablets, and the package insert has a really lengthy discussion on how to give the 20 milligram packets to patients who can't take solid dosage forms. It was way too much to put on a slide, so I see the package insert if you want more information on that. Its dosing for its FDA-approved indications are weeks 1 and 2 for adults is 400 milligrams once daily, and then weeks 3 through 24 is 200 3 times weekly, given about 48 hours between doses. For pediatric patients 5 years of age and older, it is actually weight-based dosing. So for patients less than 15 or less than 30 kilos, they actually get half of what's actually indicated for adults. And then once they reach 30 kilos, they can go on the adult dosing regimen. One thing to note about bedaquiline tablets is they must be administered with food to help increase its absorption. There was actually a study on bedaquiline salvage therapy in NTM lung disease. And these are patients greater than 18 years of age, and they all failed various treatment regimen times with other medications. And so they went into this salvage therapy mode where bedaquiline was used as part of a multi-drug regimen for the treatment of Mycobacterium avium complex and Mycobacterium abscessus. And the treatment duration was a minimum of 24 weeks. And the dosing that they used in this study is the adult dosing that's listed in the package insert. So for results, 90% of the patients had symptomatic improvement with decreased cough, decreased sputum production, and other symptoms. Radiographic outcomes at 6 months looking at CT scans, 40% of the patients had improvement, 20% of the patients had stable or unchanged CT scans, and then 40% of the patients had worsening. 20% of the patients had no identifiable improvement in sputum scores, and 50% had one or more negative cultures. And 60% did have GI adverse effects, just to let you know, which is generally regarded as nausea. And another concern with bedaquiline is QTC prolongation, and over the course of these treatments, they had minimal changes in their QTC values. So not bad results if you're having to put somebody on salvage therapy for NTM disease. Okay, so what about monitoring? Again, EKGs are really important with this medication. So get them at baseline, and then it's recommended at weeks 2, 12, and 24. Liver transaminases at baseline and monthly, and then also checking electrolytes at baseline and then routinely focusing on calcium, potassium, and magnesium. Drug-drug interactions, just to let you know, bedaquiline is a substrate for CYP3A4. But it does, from what I was able to find, it's not an inhibitor or an inducer of the isoenzyme. Medication and patient procurement. This is one of the most annoying things about this medication. So I grabbed this schematic from the access guide. So it is a limited distribution in the United States, okay? There is one specialty pharmacy that is allowed to dispense it, and that is this Metro Medical. So you have to call them, or the provider has to call them and initiate the process. I think there is, for full bottles, there is something through the wholesaler, but I don't have experience with doing that. All of my experience has been with patient-specific prescriptions. Patient-specific prescriptions are sent to the specialty pharmacy, and then the medication is actually distributed directly to the healthcare provider who prescribed it. It does not come to the patient. And this is because the medication and the patient education materials that are in there are specifically for directly observed therapy for TB. So every month, at our clinic, we have ID specialists that will come and deliver the bedaquiline to our patients in our CF clinic that are using it. So let's switch gears a little bit to omadacycline. Omadacycline is an aminomethylcycline within the tetracycline class that is approved for use in adults with community-acquired bacterial pneumonia or acute bacterial skin and skin structure infections. That is a lot of words. Its mechanism of action is that it binds to the 30S ribosomal subunit to block protein synthesis. And the dosage forms on the market are 100 milligram single-dose vials for injection that equals 131 milligrams of omadacycline tosylate and 150 milligram tablets that equals 196 milligrams of omadacycline tosylate. For dosing for the improved indications, the dosing listed is actually in milligrams of omadacycline. For community-acquired pneumonia, loading dose depends on if you're using IV or oral. For IV, it's 200 milligrams times 1 on day 1, and then or 100 milligrams twice a day on day 1. And then for oral, that's 300 milligrams twice daily on day 1. And then they can go on to maintenance dosing of 100 milligrams IV once daily or 300 milligrams orally once daily. For skin and skin structure infections, the loading dose is pretty similar to the cap loading dose, except for the oral tablets. The oral tablets, you would give 450 milligrams once a day on day 1, and then repeat that dose again on day 2. For maintenance dose, it's again similar to what is listed above at 100 milligrams once daily for IV or 300 milligrams once daily for oral. For tablet administration, omadacycline needs to be taken in a fasted state, and it's actually documented that the patient needs to fast for 4 or more hours before they take it, and they can only take it with water. And then after they swallow the tablets, no food or drink except water for 2 hours after taking it. And then no dairy, antacids, or multivitamins for 4 hours after taking the medication. And that's because food and cations actually inhibit the absorption of omadacycline into the body. Omadacycline actually had a case series on its use in non-tuberculous Mycobacterium pulmonary disease. So for case 1, This was actually for first-line treatment. This was not salvage therapy. In case one, it was a 65-year-old female. Her first-line treatment was amikacin 750 milligrams 3 times a week, imipenem 1 gram every 12 hours, and they actually skipped the loading dose and just put her on 300 milligrams daily. And changes to the regimen over the course of the treatment was amikacin was changed to inhaled after 6 months and imipenem to clofazimine after 1 year. Her treatment duration was 18 months, and she saw improvements in clinical symptoms with a 7-kilo weight gain, no shortness of breath, and decreased cough. The CT scan also showed no significant changes, and all cultures were negative since initiation of therapy. Case 2 was similar in age and gender, and the first-line treatment for this patient was amikacin 15 per kilo 3 times a week, azithromycin 250 once a day, and then again, they skipped the loading dose and just put the patient on 300 milligrams of omadacycline every day. They didn't state why, but all medications were stopped after 9 months. But the patient saw improvement in clinical symptoms with no shortness of breath, hemoptysis had resolved, and slight weight gain. And CT also showed no definite abnormalities, and cultures were negative after 3 months of therapy. Case 3 is kind of what we may see sometimes in our centers, is a 35-year-old male, amikacin 1,500 milligrams IV Q Monday, Wednesday, Friday, imipenem 1 gram Q12, and 2 months after initiation of these antibiotics, they added omadacycline 300 milligrams once a day, again skipping that loading dose. Unfortunately, the patient relocated, so that's why I was saying this is kind of more of a real world type thing. So the patient actually was changed to inhaled amikacin, and imipenem was changed to clofazimine for ease of transition to where they were going. And unfortunately, they had to stop the omadacycline due to access issues for the patient. So he actually got 16 months of treatment. And in that 16 months, he saw improvement in clinical symptoms. Cultures were negative for 3 months, and they stayed negative for greater than or equal to 3 months, but then they turned positive again. So kind of some interesting results with this. Not a lot of pediatric data out there, but what I will say is on clinicaltrials.gov, omadacycline does have a study that's currently ongoing for pediatric pharmacokinetic with IV and enteral dosing. So hopefully that'll be published soon, and the pediatric centers may have access to a little bit more information about this drug. For monitoring of omadacycline, liver transaminases every 2 weeks at administration, and GI adverse effects and infusion site reactions. Drug interactions, it's a substrate for P-glycoprotein and ABCB1, and there are some drug interactions with anticoagulants and antacids. So let's talk real quick about tadizolid. Tadizolid is an oxazolidinone, FDA approved for patients greater than 12 years of age for skin and skin structure infections. Mechanism of action is that it binds to the ribosome subunit to block protein synthesis. Dosage forms are 200 milligram IV vials or 200 milligram tablets. And the FDA approved dosing is here for 200 milligrams IV once daily or oral 200 milligrams once daily. And the tablets can be given without regard to food. So not a lot of data out there on tadizolid use either with regards to use in NTM disease, but there's kind of been some of these studies looking at maybe PK data in CF patients and stuff. So oral bioavailability, pharmacokinetics, and safety in persons with CF that are greater than 12 years of age have been shown to be similar to healthy volunteers. And I was actually able to locate one study evaluating tadizolid pharmacokinetics in patients less than 12 years of age. And that study, if you read through it, actually gives some insight as to potential dosing for patients less than 12 years of age, given different age ranges. And there was another study that looked at sputum to plasma concentration ratios in patients with CF, and they found that it had a good penetration into the lungs, so a potential therapy there. And then I just put in here some tidbits about NTM disease, is that tadizolid was shown to have in vitro activity against the different strains, And tadizolid actually had lower MICs against MSSs than linezolid. So for those of us that have used linezolid for NTM disease, this could be another option for that. Monitoring, it's basically like what we are familiar with linezolid, CBCs, but tadizolid does have lower incidence of bone marrow suppression than linezolid. And drug interactions are listed here. Really one of the biggest one is just remember that they are reversible inhibitors of monoamine oxidase, so be careful with MAOIs and other serotonergic medications. So in conclusion, in the era of highly effective modulator therapy, rifampin and clofazimine may have less utilization due to drug-drug interactions or potential drug-drug interactions, like I highlighted here. Bedaquiline, omadacycline, and tadizolid are possible alternatives that can be used for patients with CF, but further studies are needed, especially in the pediatric population where studies are ongoing or the information is just lacking for those patients. All right, thank you.
All right. All right, so we have about 5 minutes for questions. We have some great questions rolling in. In standard MAC treatment, can you speak to the efficacy of 3 times weekly dosing versus daily in adults and peds?
In which did they state a medication?
They did not.
Oh, amikacin. So this probably goes out more to the adult population, which I do see a little bit at my center because we transition at 21. There is a lot of literature out there on amikacin 3 times weekly versus once daily. And one thing to remember is that Mycobacterium abscessus strain, or Mycobacterium strains, non-tuberculous Mycobacterium strains, sorry, actually take 5 days to replicate on a Petri dish. They're called rapid growing Mycobacterium, but they take 5 days to replicate. So they're actually slower growing than what we normally see with Pseudomonas. So we're not worried about prolonged time without drug, just as long as you don't go like longer than 3 days or 2 days between dosing for that.
Okay. And then the next question for omadacycline, while using for off-label use, how are you able to get patient financial assistance?
So that is something that, especially at a pediatric center, I did have a patient that came into my center on omadacycline. So it was a lot of discussion with the insurance company because they are outside. A lot of times it is outside the indicated usage. But it was a pretty quick PA process. Just submitting information to the insurance company, and it was readily available in the pharmacy. It was actually, for those that are familiar with Kroger, it was dispensed by our Kroger pharmacy that was local to the patient. So that's actually one of the easier ones to obtain. But for some insurance companies, it may be, or patient assistance may be a little bit of a conversation.
Next question. How is your clinic handling patients who are on NTM treatment but no longer produce sputum? Induced sputum, surveillance, bronchospochy, etc.
Yeah, so that is a big one. And we're actually having issues with this just with our routine cultures where patients can't produce sputum anymore. We do try to utilize induced sputums, mostly in our inpatient admissions. If they're outpatient, they'll do various things, try to get an epiglottic, which may not be the most beneficial for patients greater than 5, but we do, if they're inpatient, we will try and induce sputum in the PFT lab. But if that doesn't work and we're really stuck and we're really worried about the clinical course of a patient, we will take them in for a bronch and do a BAL culture.
Okay. If clofazimine is the only available medication through insurance, do you recommend increased monitoring despite being a weak inhibitor?
So clofazimine, just to let you know, is not going to be covered by insurances. And it's like at our center, it's dispensed through the investigational drug services pharmacy because it does have, we have to do IRBs and patient-specific INDs. But we have used clofazimine still at our center. And given the information that's now out about that it's probably more of a weak inhibitor, we actually still do full dose CFTR modulators at our center. But we don't check levels or anything like that. We just monitor the patient for efficacy, and we monitor the patient for any potential side effects.
Okay. Looks like we have time for one more question. How does your center withdraw bedaquiline? Are there strategies to consider with its half-life?
Oh, that's interesting. So most of the data on here is for 24 weeks, but that's all that's been studied. The one patient that I have at my center that's on bedaquiline has been on bedaquiline for longer than 24 weeks, so I don't have any experience with weaning it or anything. If it's something that you're worried about, I think that is a clinical consideration, but has anybody else had any experience with trying to take patients off of bedaquiline, and if you tapered it off, or did you just stop cold turkey, or? You just stopped it? Were they on it for longer than 24 weeks? Yeah, so you just kind of let it do its own self-taper with the long half-life and everything? Okay, any issues? No? Okay. Okay, awesome. Awesome, thank you for that.
And thank you, Brad.
Awesome, thank you. I'll let you do that.
Thank you. Okay. All right. Our next speaker is Dr. Catherine Hobart, who completed her Doctor of Pharmacy at Duquesne University in Pittsburgh, Pennsylvania, then went on for 2 years of postgraduate training. She is a clinical pharmacist for the Pediatric and Adult Cystic Fibrosis Center, as well as a pediatric inpatient clinical pharmacist at Banner University Medical Center in Tucson, Arizona. I will now turn it over to Dr. Hobart, who will be going over the not-so-fungi and cystic fibrosis, allergic bronchopulmonary aspergillosis.
All right. Thank you for the introduction. I have no financial disclosures for today. However, like Brad, I will be discussing various off-label uses of medications. By the end of this presentation, you will be able to define allergic bronchopulmonary aspergillosis, which I will refer to as ABPA, in patients with CF and recognize diagnostic criteria, explore the treatment options for management of ABPA in patients with CF, and finally manage critical drug interactions in the era of highly effective modulators. So as a brief review, allergic bronchopulmonary aspergillosis is an IgE-mediated allergic response to Aspergillus fumigatus. So that is a very common fungal spore in the environment. So with repeated inhalation and exposure, that fungus can get stuck in the thick and sticky mucus, which causes the cascade of airway inflammation, bronchospasm, and the hallmark central bronchiectasis, which can contribute to overall pulmonary decline. The reported incidence in the literature ranges from 1 to 15% of our patients. However, in the most recent available 2020 CF registry data, it suggested that about 5% of patients with CF are also diagnosed with ABPA. For the purpose of this presentation, I would like to focus on the diagnostic criteria set forth by the 2003 CF Foundation consensus guidelines. However, in the literature, there are various diagnostic criteria that is available. And so to compare and contrast the classic case and the minimal diagnostic criteria, both of those require a patient to present with clinical deterioration that is unrelated to another cause, which is difficult because what's defined as clinical deterioration is coughing, decreased pulmonary function, decreased exercise tolerance, which is directly aligned with most of our other acute pulmonary exacerbation symptoms. And so diagnosis can be difficult and often underreported. In the classic case, the serum IgE should be greater than 1,000 units per ml, where in minimal diagnostic criteria, it can be 500 or over. Both require IgE antibodies for Aspergillus fumigatus, as well as IgG, and clinical imaging findings, specifically with CT, as that's the higher sensitivity imaging. And the hallmark sign, again, is central bronchiectasis. So for the goals of treatment, once a patient is diagnosed with ABPA in CF, the ultimate goal is to control the symptoms that is contributing to the acute decline, prevent or treat acute pulmonary exacerbations associated specifically with ABPA infections, and ultimately slow the progression of disease. To do this, we need to attenuate the inflammatory and the immunologic response, as well as decrease the fungal colonization. And with both of those, that requires significant pharmacologic intervention, which could potentially pose some adverse effects and drug-drug interactions, which need to be mitigated and monitored. So in the 2003 consensus guidelines, which are still the most up-to-date guidelines, so as Brad referred to his old but good, or really old but good, the only two medications that are recommended are prednisone and itraconazole. And so as time has passed, almost 20 years later, there are a lot of case reports and literature supporting additional therapies, such as IV methylprednisolone, other oral antifungal medications such as voriconazole and posaconazole, as well as inhaled amphotericin B. And one of the more common reported medications is the biologic agent omalizumab, specifically in patients with CF. There have been other biologic agents studied in patients that have ABPA and asthma, such as dupilumab, benralizumab, and mepolizumab. However, in patients specifically with CF, this had not been as reported upon. And so you can see here that going back to the goals of treatment, the steroids are going to moderate that immunologic and inflammatory response, while the azoles are going to target your fungal burden. And the omalizumab, which is an IgE specific biologic agent, will also help with that immunologic response. So to start off and review the guidelines, the mainstay of therapy that is still primary and first-line therapy is steroids for long periods of time that are slowly tapered upon by patients' response to therapy and clinical presentation. And so this is still like I said, the hallmark treatment, and it helps with that immunologic and inflammatory response. It has also been shown in some of the literature to decrease the favorable environment for Aspergillus growth, so that can also somewhat help with the fungal burden. However, as we all know, that long-term steroids have significant adverse effects. And so some of the concerns in patients specifically that have CF who are already predisposed to diabetes and osteoporosis is that steroids will increase these risks. Additionally, it can decrease the immunologic response, which I have seen play a significant role in some of our patients who have been treated with long-term high-dose steroids who have developed secondary infections that needed to be treated in combination with their ABPA. Additionally, it can cause cataracts, which can be a concern in our pediatric population, specifically with CFTR modulators, which may also cause cataracts. Not that it's an additive effect, but just one more thing that could potentially cause that risk. Switching over to itraconazole, this is our second-line therapy that is added on when a patient fails to respond or is unable to be titrated off of their high-dose steroids. And really, it inhibits the fungal cell wall synthesis and does pose significant interactions with our CFTR modulators and as well as some of our other chronic medications, because it does require an acidic environment for absorption. And so many of our patients that are on PPIs or acid suppressive therapies can have interactions with this medication and decreased absorption. So over the last 20 years, there have been a lot of case reports, and so I would like to highlight some of the literature that is available to support additional treatment modalities for ABPA. But again, as I have prepared, I noticed that there is a very large paucity of literature actually supporting hard, good evidence. So most of this is reliant upon case reports. So the first case report that I would like to highlight was evaluating IV pulse methylprednisolone versus oral prednisone in the management of ABPA. This case series included 9 patients who received IV methylprednisolone and 5 patients that received oral steroids. You can see the dosing here where the IV methylprednisolone was given a 10 to 15 milligram per kilogram dose for 3 consecutive days every 4 weeks. And with this, you can see on the graphs there that showed a significant improvement in their FEV1 as well as a decrease in the serum IgE levels. And so one of the hallmark advantages of this IV methylprednisolone when compared to the oral prednisone group is that they had significantly less adverse effects, specifically less weight gain, less cushingoid appearance, and decreased emotional instability, among other adverse effects that were seen within the oral steroid group. The patients that were in the oral prednisone group, 4 of the 5 of them, that as soon as they started to titrate their dose down, they had to increase their dose due to return of respiratory associated symptoms and clinical deterioration. And so with this case series, I would suggest that methylprednisolone is an effective alternative to oral steroids and has less adverse effects. Another case series did suggest that there were patients who did develop hypertension in the times that they were receiving the IV steroids, but that was able to resolve upon discontinuation. I'm just going to briefly touch upon the oral azole group. The itraconazole is the only one, like I said, that is recommended in the 2003 guidelines, but it does have variable kinetics and absorption and can be difficult to obtain appropriate monitoring with the levels as an outpatient therapy. And so that did show to have improved lung function and steroid-sparing effects, which could potentially be a result of the the drug interaction between steroids and azoles, as well as improved serology. But that was also seen with voriconazole and posaconazole. So those 2 other azole antifungals should not be rolled out as an option in the management of ABPA. The additional treatment that I would like to review is inhaled amphotericin B. This causes cellular death by binding to the membrane ergosterol, causes lipid perioxidation, and protein ATPase inhibition. There is a post-antifungal effect and peak concentration dependent, and there are various dosage forms available. And so the first case series that I would like to review was a patient that was treated initially at 12 years of age for ABPA. This patient was put on itraconazole as well as prednisone with very minimal to no clinical response to that therapy. And so the patient actually discontinued itraconazole and was transitioned to voriconazole due to adverse effects associated with itraconazole. The patient still failed to respond and was placed on inhaled amphotericin B and was able to come off of the therapy, had resolution of their symptoms, but then relapsed again at 18 years of age. Again, the patient had attempted itraconazole and prednisone, but failed to respond again and developed the very cushingoid face as well as osteoporosis and was transitioned over again to inhaled amphotericin B. Once the patient was transitioned to the inhaled amphotericin B, they were able to completely come off of their steroids. They showed complete resolution of the radiographic changes on imaging, as well as improvement in bone density upon discontinuation of the steroids. So that was one treatment success. The next case series supporting amphotericin B was a group of 7 children and adults that had difficult to treat ABPA. And these patients were either unresponsive to first-line and second-line therapies, unable to tolerate due to adverse effects, or potentially have contraindications to therapy. And so this case series had 6 of the 7 patients were successfully treated, which was defined as coming off of steroids for 12 months without any relapse in ABPA-related symptoms. And so 5 of these 6 children and adults demonstrated improved lung function, and depending upon what they were able to tolerate in terms of formulation is what the patient was being administered. And finally, I would like to briefly review 2 case series that discussed the use of omalizumab in patients with CF. And there are way more than 2 case series out there at this time, but these are 2 that I really wanted to highlight. And they were both retrospective observational reviews in patients that had CF that were failing to respond to primary treatments. So the first was a series of 27 patients that was primarily assessing the efficacy and the safety of omalizumab in patients with CF that had difficult to treat ABPA. And this demonstrated that the patients were able to tolerate with no adverse effects and did experience steroid-sparing effects as well. And so they dosed the omalizumab based off of the serum IgE levels as well as body weight and did not exceed 375 milligrams every 2 weeks, which is similar to what is available in the omalizumab package insert. And like I said, these were in patients that were very difficult to control. So that one demonstrates that omalizumab can be a very well-tolerated medication option in patients with difficult to treat ABPA and can potentially help decrease steroid and have steroid-sparing effects. The second case series was a multi-center retrospective observational study that included 32 patients that also had difficult to treat ABPA, but these patients specifically had to meet the CF Foundation diagnostic criteria. They utilized the manufacturer recommendations upon dosing, so based off of serum IgE and weight, and the median dose was 450 milligrams per month. 32 of the patients were prescribed concurrent steroids, and with those, 5 of them were able to discontinue steroids completely upon initiation of omalizumab, while 9 patients were able to decrease their dose significantly, which is another hallmark of this medication. There was no significant change in FEV1 or pulmonary function with either of these, so it doesn't necessarily restore the damage that has already been done, but has again showed to be a safe and well-tolerated medication therapy with steroid-sparing effects. So as a brief summary of our medications that are available in treating ABPA, still steroids are considered our first-line therapy, but does have potential for significant adverse effects. Azole therapies do have steroid-sparing effects that are really important, but pose unique challenges in the modern day of CFTR modulators. Inhaled amphotericin also has steroid-sparing effects and improvements in lung function, while biologic therapy is steroid-sparing and has decreased exacerbations, but still needs additional information in people with CF. So as I reviewed those brief medications, looking at the drug-drug interactions associated with current CF modulators is very challenging. Additionally, other chronic CF medications can impact the efficacy of these medications. And so, as I had alluded to prior, that steroids and antifungal therapy may have a drug-drug interaction where the antifungals can increase concentrations of the steroids, while our chronic acid suppressives can decrease concentrations of itraconazole and posaconazole, while voriconazole increases our concentrations of those PPIs. So those present unique difficulties. And as you can note here, that all of these azoles are a inhibitor to CYP3A4 in varying capacities. So itraconazole and posaconazole are considered strong inhibitors, while voriconazole is considered a moderate inhibitor. So looking at the substrates of these enzymes and our CFTR modulators, it's noted that ivacaftor, tezacaftor, and elexacaftor are all substrates of CYP3A4 enzymes, which require significant changes in our administration when co-administered with these medications. And so ivacaftor, lumacaftor, ivacaftor, tezacaftor, ivacaftor, and elexacaftor, tezacaftor, and ivacaftor all do provide recommendations in how to adjust for these therapies. And so the alternatives, depending upon the strength of CYP3A4 inhibition, can change how you're going to give these medications to your patients and potentially considerations in monitoring. And so future directions in the management of ABPA, we do need ongoing studies to evaluate biologics and additional biologics. As I mentioned, they're being looked at in patients with asthma, but not specifically with CF. I am noting that inhaled itraconazole is a potential for future therapies, as I had a very adamant patient come to me and say, I want to put on inhaled itraconazole. And I looked at him and I'm like, huh? So I had gone to the literature and reviewed it. It has gone through phase 1 studies and was initiated into phase 2 studies. However, it was discontinued due to the COVID pandemic. So that may be something that can be coming down the pipeline and be reassessed in the future. We need to continue to assess the CFTR modulator impact on the incidence of ABPA. So as alluded to in the previous session, we're having more and more difficulty obtaining sputums and identifying these infections in the respiratory tract. And so with modulators, I'm anxious to see if that incidence continually decreases. And finally, encouraging clinicians, healthcare professionals, pharmacists, to please report all of your successes and failures, because as I had reviewed and prepared for this, I noted that most of the literature is coming from case reports, whether it be positive or negative. So please continue to report what you're doing. And finally, it would be very beneficial to have strides to unify the diagnostic criteria as well as the management in these complicated fungal infections, because as mentioned, there's various diagnostic criteria and treatment approaches. So in conclusion, ABPA is an IgE-mediated Aspergillus fumigatus reaction in patients with CF that can have detrimental outcomes. The current guidelines are a consensus report, and as I'd mentioned, they're getting kind of old. And so the literature that is available is primarily case reports, and pharmacists can play a vital role in the management of the safety, the efficacy, and monitoring of drug-drug interactions. And I encourage all of you and your healthcare teams to continue to report all of your success and failure. So thank you for your time today, and I'd like to answer any questions.
Thank you. So the first question, and you could possibly outsource this to the audience, is there was a question asking if anybody has used Cresemba for ABPA.
I personally have not used Cresemba for ABPA. Does anybody in the audience have experience using that?
Catherine, we did do a separate, I think you used one of those articles. We actually in that, there is some information on it, but not very much.
Yeah.
But there is some dosing information, there's some studies in CF that we used.
Okay, awesome. So the 2003 guideline recommends 5 per kilo per day for itraconazole for ABPA, but newer literature shows that this is likely subtherapeutic. What doses are you typically starting patients at, or are you starting there and then adjusting?
I would start there and then adjust as needed for monitoring. However, to be honest, I haven't had a patient recently put on that with monitoring parameters due to difficulties obtaining them.
Okay. And then kind of going along with that, how often do you monitor antifungals?
That's a good question. So monitoring it takes a while to get to steady state. So you would have to obtain your levels after some time that the patient is on there, and then just ensuring that the patient remains therapeutic over time. So if there's any changes in clinical status or any changes in drug interactions that could potentially change your concentrations is when I would recommend monitoring.
Is there any evidence to start vitamin D and calcium supplements while on steroids for ABPA, or have you used that practice?
That's a really good question. I have seen some of our patients that have been put on calcium and vitamin D supplementation while on steroids. However, I did not come across any literature in that in my review.
For one of your first omalizumab studies, pretty much everyone was on the highest dose for their weight. Have you needed to restrict a dose or anything with regards to that, or they're kind of curious as to what was the case?
Yeah, and so the dosing of omalizumab has not been consistent in the literature for patients with CF, so it's pretty challenging to unify that dosing scheme. In my experiences, I've used the manufacturer labeling based upon several of the other case series that have been reported out in patients that have CF.
Is there anything in the literature, or have you had experience with switching between azoles?
There is some support in the literature just upon patients' tolerability of one azole versus another azole. However, I have not had personal experience switching between the azoles.
And then if you don't switch between azoles and somebody's not responding, would you switch to a biologic at that point?
Yes, I would consider biologics, especially if the patient is not responding to therapy. And the other change in some of our practices is we've tried to use biologics as steroid mitigating in those very high-risk patients that we're concerned about initiating steroids.
I have a question for
Yes.
you. So this is something that comes up a lot in talking with my colleagues at my center is for voriconazole, the level therapeutic range is like 1 to 5, but now some of my colleagues say that they use more like 1 to 2 for prophylaxis or 2 to 5 for treatment. So in ABPA, what levels have you shot for voriconazole?
I personally have not shot for levels yet. However, if I were working, I would probably push closer to the 2 to 5 range, especially determining the patient's clinical response.
Okay.
Yeah, I would probably go higher.
And then somebody was wondering if you could give a little bit more insight about inhaled itraconazole, like what dose and how did you prepare it?
So the inhaled itraconazole was not done, so I did not explore that option. I did look in the literature. I can't recall the specific dose. However, it was shown to be safe and effective in phase 1 therapy studies. So there's really not good literature out there yet. And so I would not recommend it at this time. But I'm anxious to see that phase 2 study come back to light and see how it plays in our ABPA treatments.
Awesome. I think that's all of them. So,
Thank you.
Thank you very much.
Thank you.
Thank you, Catherine. Okay, and that brings us to our final speaker is Daniel Killian, who's a certified pharmacy technician in the Adult Cystic Fibrosis Center at the University of Utah Hospital in Salt Lake City, Utah. In this role, he assists patients with refilling medications out of the university's pharmacy system, as well as assisting all CF patients with access and affordability of life-saving treatments. I will now turn it over to Dan, who will present the ins and outs of transitions of care as a pharmacy technician.
Good morning, everybody. Oh, I skipped that one. I don't have any relationships to disclose. I've been a pharmacy tech for 6 years, and I'm in my 3rd year of working at the CF clinic. So my main responsibilities what did I just do? There we go. I'm going to put that down. So my main responsibilities are working on benefits investigations for patients' insurances. That includes a lot of different things that I might touch on a little bit later, but usually it's figuring out if their specialty meds need any prior authorizations. There are modulators like Dornays. Sometimes their inhalers need prior authorizations. So if we've determined they need prior authorization, we'll work on those. A big part of that is figuring out which pharmacy they're restricted to fill with. Then we coordinate refills for patients filling within our health system. We do have a specialty pharmacy at the University of Utah, so that's great. We also help monitor refill adherence for patients, and then we work on affordability for them. So we help sign up for copay cards, we help them sign up for any of the third-party grant assistances, and then we also see patients in clinic that have any needs for pharmacy technicians. So that's usually like if they're having problems affording a medication, our team will let us know and we'll go over and talk to them about that. So with benefits investigation, we usually figure out their insurance, and that's pretty tricky sometimes if they don't bring their cards in. So we have a few different resources that we use. We use Epic for the EMR that has a few searches in it that help us find the information. And then again, we're determining if their meds, CF and non-CF meds, need prior authorization. And then we'll also inform the clinical staff if there are alternatives that are preferred over the med that they're already on. And then we're also looking at plan specifics. So that's things like deductible and max out of pocket. We can help identify if their plans are part of a copay accumulator or maximizer. And then we also field calls from patients during open enrollment. That's a big anxiety for a lot of patients because, as you all know, they're on so many meds and it's hard to find information about like what treatments you're on. We specifically run into problems with that with patients that are going on Medicare. The search tools that are there are pretty lacking sometimes, so we get calls from patients all the time saying, I found out my Trikafta is not going to be covered next year. And so we have to ease their anxieties and just let them know that that's usually not the case. We'll look on like Medicare.gov with them and just see, well, I found like 5 or 6 plans in your area that say it's covered. And then affordability is probably one of the big parts. We always want our patients to be able to afford their medications and not have to pay as much as possible. So we check and determine if they're already enrolled in copay assistance programs. We'll help them with HealthWell Foundation, the Assistance Fund, there's the Patient Advocate Foundation, and then we'll even help do applications for manufacturer patient assistance. So on the prior auth front, we actually complete and submit the prior auths. So we're pulling the clinical criteria and determining if that patient does meet those criteria or if potentially there needs to be a medication change. And then we're proactively managing their prior authorization renewals as well. That's a really big part of it because a lot of places that I've worked for or worked with, I noticed that like a prior auth will get needed and then the doctor's office will submit it. And then usually it has to be renewed within a year. And that usually doesn't happen at most centers or in most offices. So we've really tried to take a proactive measure and about a month before it's set to expire, we're already working on it. And so this is the traditional CF pharmacy care model. So when a patient's seen outpatient, if they're getting admitted, there's a gap here to being inpatient. So we help fill that gap. And then same with going from inpatient to outpatient, there's another gap. So what we do is kind of just help patients get into the hospital, make sure, their meds are there that they need. It's usually their modulators that most inpatient pharmacies don't have access to. Then on the outpatient side, we help, So we make sure any new start medications are approved through their insurance. We help with discharge and the like. So we've taken it to a continuous care model. And as you can see, we put the patient in the center, and we kind of go back and forth between inpatient and outpatient care. And then the data here on the left is just our FTEs from 2005 to present. So as you can see, we've added a few FTEs lately, and we're actually working on trying to get another one approved for our center because we are getting really busy and help is needed. So I'll touch a little more on what exactly we do when a patient's going from outpatient to inpatient. So a lot of times the clinical pharmacists on the floor will ask us about their medication adherence, and it's especially with patients that are frequently admitted because that could be a big key to why they're continuing to go back in. We'll also notify the multidisciplinary team of their access to therapies. So we'll get a lot of questions like, well, are they getting their modulator? Are they getting their Dornase? We have one of the highest patient contacts in our center just because we're constantly working with the patients and especially when we're refilling their medications. So we're contacting them monthly. Then we can also assist with access to the highly effective modulators or just normal CFTR modulators during the inpatient stays. There's a few barriers for the modulators in the inpatient setting. Like I said earlier, there usually isn't access in the inpatient setting. I think some pharmacies can actually get it, but most don't want to carry them because they only come in set packages, and breaking boxes is usually not a good idea. So we have patients that sometimes forget to bring it with them at admission. Sometimes they're long distance from home. We see patients from Nevada, Wyoming, Montana, and Idaho. So if they forget to bring it in, their family might have to turn around and go back, and that could be 5 or 6 hours drive. So what we're able to do is, since we have a specialty pharmacy, we can usually fill a modulator for the patients. This, of course, depends on their insurance and if they're being restricted. I think, as we all know, that's a headache. So in most cases, we're able to get that modulator delivered the next day. Sometimes we can even have it there the same day, just depending on the time we find out. And then, so when they're discharging from inpatient to outpatient, we assist with discharge orders. So we're usually contacted by our pharmacist on the floor, and they'll let us know that these are the expected meds for discharge. Usually it's like new starts, antibiotics. So we're able to deliver them to their bedside, or if the patient prefers, we can help arrange them for pickup in their preferred outpatient pharmacy. A lot of times it's in our pharmacy in the hospital. We also will work on prior auths for new medications that are started in-house. So we're usually notified early of those new starts. A lot of times it's like Aztreonam, or if they're starting a modulator, we can get that prior auth in place before they discharge. We also work on test claims. This is a really big part of what we do because we're trying to determine the patient's out-of-pocket cost and then see if we need to enroll them in any copay cards. So a big part of that is with inhalers because there's so many different ones, and insurances always prefer, this one or this one, but not this one. So we're checking all of those for what the insurance prefers. We identify if it needs a prior auth and the like. And then we also help with specialty medication access program enrollment. So the big one is for inhaled Aztreonam. They have their access program, and then also the CFTR modulators, which is Vertex GPS. So if any patients aren't enrolled in that, we'll work with them to do that, get them to sign it and send it in for them. And then I also wanted to touch on that we work with general pulm as well. So there's 2 techs at our center right now. And we're also working with asthma and some ILD patients. So we're really busy, but we kind of do all this to help support the clinic as a whole. And I think that's really important because if centers are trying to get some access to technicians, they maybe can work with general pulm as well to have more of a like data or more of a say, I guess. And that is everything I have today, so I'll turn it over for questions.
So a question that came in is, does your specialty pharmacy or institution have restrictions on when you can process CFTR modulator refills and when a patient is admitted and stuff? So
Yeah.
any restrictions
No,
on that?
that's a great question. So sometimes we're able to fill the medication before they actually are admitted. So we don't usually have to do anything special, but we also will just call the insurance, the PBM, the help, like pharmacy help desk, and we'll ask them for permission to fill it during their inpatient stay. Sometimes the people we get don't understand what we're talking about, so it takes a little bit of time for us to tell them why. And then we'll just document it in our ambulatory pharmacy system so that when our auditors go through, they're not wondering why we filled it when they're admitted.
Okay. Awesome. Sorry, things are moving on me. How do you identify if plans are copay accumulator or maximizer plans? And if you are delivering the CFTR modulators to the bedside, how do you rectify that with the 340B requirements?
It's a great question. I'm not an expert on 340B, but I can touch on the other part. So it was.
How do you identify if plans are copay accumulators?
So
or
there's
maximizers?
some language you have to look out for, and it's blinking my mind right now, but Vertex actually sent out some documentation on that. So usually it'll say things like the specialty med is restricted from their out-of-pocket, or a lot of times we're able to do test claims just to determine that. And it's a good indication when you fill it in January and then they have a copay the next month, because most modulators are really expensive. So that usually takes care of their deductible. And if you want, you guys can contact me and I can help you learn that lingo. I just haven't looked at those that information Vertex sent for a couple weeks. And then on the 340B side, that'd be something I would have to bring up with my colleagues because I'm not sure. Like I said, I'm not an expert on it, but with delivering the modulators, we usually will take them to the bedside, or I'll take them to the pharmacist that's on staff, just because some patients, are in treatments or doing PFTs or asleep, so we don't usually want to bug them.
Awesome. It looks like we have some questions coming through about like different assistance programs now that there's kind of some changes to grants and stuff.
Yeah.
Have you found any other grants that are similar to HealthWell since there's kind of changes going on with that?
Yeah.
And also, what steps have you taken to prepare for Vertex's new assistance model?
So I'm going to go back here. How far was it? So we have the HealthWell Foundation for grants. There's also the Assistance Fund that offers a CF grant, and the Patient Advocate Foundation. So the Assistance Fund is a great one for patients with Medicare because they don't have an annual cap at this time. It could be changing. I haven't heard anything. So it's helpful for Medicare patients because their out-of-pocket costs are pretty high, especially with the CFTR modulators. I think the cost for a year is like $25,000 for their out-of-pocket costs. So HealthWell Foundation is $15,000 for the year. that doesn't get you very far. What we do is we monitor those funds for patients because we have portals for all of them. And if they're on the Healthwell grant and they're getting close to being out of funds, we'll let them know and we'll check to see if any of these other funds are open, and we'll help them enroll in those as well. There's a second part to that, right?
Yeah, there's two that kind of come through to talk about the Vertex
Vertex.
copay assistance changes. So how are you involved in that?
So Vertex reached out to us a little earlier than their email blast, and they let us know of the changes. So we've kind of been strategizing, and as Vertex has called some of our patients, they've been calling us to figure out like what's going on. A lot of our patients trust us with these things, which is great. But what I do is just kind of explain it in terms they can understand. So I don't want to go into too much depth with the copay changes, but there's kind of two buckets. There's a $3,500 and then like a $8,500 one that they can enroll in, and that's dependent on if they have a maximizer plan or not. So I just let most patients know, I think your plan right now is this one, so you should be okay. Or you have this one, so like we're gonna have to come up with some strategies. If you're going into open enrollment, I'd recommend looking into maybe a different plan if you can, those kind of things. I'm always there for patients to call and chat with me about this, because it's a really serious change, and it can impact our patients in a big way, especially if they can't afford it. I've had patients tell me throughout the years, if I can't afford it, I'm just not going to take it. And that's not what we want.
A question came through about, have you had issues getting approval for biologics, or is the process the same?
Yeah, so biologics are tricky sometimes because the FDA, has their, you guys are experts more than me, but they have their criteria. A lot of times it's like eosinophil count, exacerbations, have they been on a ICS LABA/LAMA, that kind of thing. So we navigate with the insurance during that, and we'll let our clinical team know, the multidisciplinary team, and just say, hey, this patient, their CBC doesn't show eosinophils at this, so we probably should get a new one, or what do we do? And a lot of times we end up submitting them and getting denials, and then we'll work on appeals. We'll contact our pharmacists and let them know, hey, this was denied, we need a letter of medical necessity. They'll get that back to us, and then we get everything together for appeals and submit those. And that process is really frustrating sometimes because some plans are like, yeah, it'll be 30 days. And then you call them in after 30 days, it'll be 30 more days. Come on.
Does your institution have a meds to beds program? And as a pharmacy technician, how are you involved in that if you have one?
Yeah, so we do. They have their own separate discharge pharmacy team, but we work separately from that because patients with CF are more complicated, as we all know, and their meds are usually, there's a lot, and we like to just make sure all their copays are where they're supposed to be. So with discharge orders, we'll go through the pharmacy that's in the hospital. We'll process all the medications. We'll make sure their copays are where they're supposed to be. We'll communicate with the patient, let them know, hey, this is $4. Do you have payment on you? And then if they don't have payment with them, we're able to just submit that for paper billing. And then we'll deliver them to their room if that is what they prefer.
What other systems does your clinic use besides Epic to run benefits investigations?
So we have access to something that I call MDON. It's on the internet, and it has a card finder. So you have to put in patient specifics. It's name, first name, last name, date of birth, zip code, and a lot of times you need their last four of their social. If that doesn't pull anything, then we'll call any pharmacy that they have filled with and try and get it from them. If that doesn't work, then we have to talk to the patient and ask them for those specifics. But a lot of times it's faster to call a pharmacy than the patient if they don't have their card, because it's hard to know.
And then I think this will be the last one, then we can wrap up. But is your benefits investigation team specific to CF patients, or do you guys collaborate with another benefits investigation team within your institution?
Yeah, so we do that just for the CF patients. We do it for our asthma pulm patients too, but it's less in-depth usually. But we're kind of our own separate thing. We do a lot for our patients.
Awesome. Good job.
Thank you.
Thank you.
Sure, you all are ready to stretch your legs. Thank you all for your time and insight today. I hope you all enjoyed our discussions. I want to thank all of our presenters, and a special thank you to my co-chair, Dr. McCrory, who was a pleasure to work with over the past several months. So this now concludes our session, and I hope you have a great rest of NACFC.